Okay, welcome back for our session today. This is already you know about that slide. Only thing is that website you keep noting www.drscarmia.in. My name is not SHARMA, SHARMA. South Indian Sarma, not the North Indian SHAR. drsharma.in. There you can find a lot of presentations, whichever you want. So the algorithmic approach for polyuria. Polyuria and diabetes insipidus, they go together. So whether you title it as polyuria or diabetes insipidus, it's one and the same. Of course, polyuria has got several other causes, which we will try to separate and then go into the diabetes insipidus. This slide you have already seen. And we do have total 35 liters of body water out of 70 liters or 60 liters. Why so much of water? Because we have evolved from marine life. The life has arrived, evolved from life, and so it has enclosed a lot of water inside. And then slowly we become terrestrial people. So that is why a lot of water, that too salted water, is inside. And it is not that It is not that all this water is in a can, 35 liter big tank, not that it is in one tank. In fact, there are 3 compartments or 3 tanks. One tank is the intracellular fluid, cytosolic fluid, cytoplasmic fluid, that is the cell, within the cell. That is called cytosolic water. The other one is the intravascular water, the one which flows in the tubes. So between them is the intestine. And the water cannot just freely move from the intravascular space into the interstitial space, into the intracellular space, just like that. It cannot. Why? Because there is an endothelial barrier in the capillaries. There is a cytosolic cell wall is there for each cell. So the cell wall doesn't allow water to just go in just like that. Likewise, the endothelium doesn't allow it to leak water into the interstitial. So there are many conditions to be fulfilled for the shift to occur from the intravascular to the intracellular or interstitial fluid. That is where exactly all these problems are coming. The key players are ADH, the aldosterone, oncotic pressure, and solute load in the plasma. All these things are key factors in this movement of water. So water movement is rather regulated by so many things. This we have seen, around 2.4 liters is the input and 2.4 liters is the output. And we know that urine constitutes the major output, and then water intake in the form of fluid is the major input. This also we know how to calculate the osmolality, 2 into sodium plus potassium, glucose by 18 and 1 by 2.8. Why 18 and 2.8? To translate the milligrams into milli equivalent. The hypothalamic pituitary endocrine axis also we have discussed last time. The hypothalamus has got nuclei and they have connection with the posterior pituitary. Posterior pituitary secretes a hormone called the vasopressin, also called the ADH, antidiuretic hormone. And the target organ for any hormone will have a target organ. Just like thyroid hormone has a target organ here, the target organ here is the renal tubule. Which part of the renal tubule? The collecting duct of the renal tubule. There only it can act. Because aquaporin in one channel absorbs all the water in the proximal convoluted tubule. And then they only aquaporin 3 and 4 and 2, particularly 4, they are under the influence of the ADH, which occurs in the collecting ducts and the distal convoluted tubule. Arginine vasopressin and then synthesized and secreted by the neurohypophysis includes nuclei in the hypothalamus, which the axons are terminating in the posterior pituitary. From the posterior pituitary, arginine vasopressin is released. We also know this beautiful slide where normally 4 picograms is the ADH level in the plasma. at a normal osmolar concentration of 285. If the 285 is the osmolar concentration, 4 picograms of ADH will be there. If the osmolar concentration shifts lower, that means plasma becomes dilute. See, the intravascular compartment becomes dilute. Then naturally, no ADH should be secreted. Water has to be conserved. No diuresis should occur. So antidiuretic hormone will probably come to almost zero at 280 or something. Suppose the other way around, the osmolarity increases and plasma becomes hyperosmolar, then we require water to be conserved. For that ADH is required, ADH secretion increases. In other words, if the osmolarity becomes lower, ADH is suppressed, more urine is thrown out, and serum plasma is rather concentrated. If the plasma osmolarity is higher, more ADH is secreted, water is withheld, and the osmolarity is restored to normal. This also we have seen that the control is by two mechanisms, one by the osmoreceptors, the other is by the baroreceptors. Osmoreceptors are sensitive to ECF osmolarity and baroreceptors are sensitive to the blood volume. If the blood volume is lower, naturally there is a dehydration or any reason, water is lost, blood volume is lowered, baroreceptors are stimulated. These baroreceptors act through the angiotensin 2, which is a dipsinogen. This angiotensin 2 acts on for water acquisition and then increases the circulating blood volume. Or if there is a ECF osmolarity is decreased, osmoreceptors are stimulated through the posterior pituitary, ADH is released, antidiuresis occurs, water comes. There is a feedback for this. The feedback is the ANP, atrial natriuretic peptide. Just like BNP you have for the heart failure, there is called the atrial natriuretic peptide. This is secreted from the atria depending on the stretch of the atria. So the natriuretic peptide is the feedback to reduce the ADH or to reduce the aldosterone once the things are set right. That also have to remember. This part we have seen the Bowman's capsule and this one. And the next slide also we are familiar that the PCT is not under the influence of ADH, whereas the DCT and collecting duct are under the influence of ADH, where aquaporin channels are the important ones, aquaporin 2 channel and aquaporin 3 and 4. So now we will see that particular cell there, the cell there, the bigger black color cell, the gray color cell, there is a basal part, there is an apical part. The apical part is towards the endothelium or the vascular space. The basal part is towards the urinary space. So from the urinary space, water has to move to the interstitium, from the interstitium into the vascular space. For that, there must be channels which will siphon the water from the urinary tract into the cell, from the cell into the interstitium and into the intravascular. Those channels are called the aquaporin 2 channels. They are under the influence of the arginine vasopressin hormone, which has got a receptor there. The receptor is on the apical side, and the aquaporin channel should open on the basal side. So on the apical side, when the receptor is there, the ADH comes and sits on the AVP receptor and then activates the cyclic AMP, which exteriorates the vesicles, the aquaporin tubes, and these tubes are kept on this side of the membrane. Water freely enters, comes into the cell, into this basolateral cell, and then this cell goes into and then sends the water through aquaporin 3 and 4 into the interstitium, from thence into the vascular compartment. Okay. That is how the mechanism occurs. So now we know that there is what is called primary urine secretion at the glomerular level is 24 hours multiplied by 120 milliliters per minute into 60 minutes into 24 is 170 liters. We are not losing all that. We are only excreting 1.5 liters of urine. That means there must be a lot of concentration going on through the kidney right from the time it is filtered. It is by the time it is ending in the urinary passages, it is going to be concentrated everywhere. And that concentration is to the greatest extent 99% of the water is reabsorbed. This is the best example of water conservation in the body. Only 1% is finally excreted. 79% of the water is absorbed in the PCT. Remaining 70% is absorbed in the PCT, 29% in the DCT by the aquapore in 2, 3, 4, and the remaining 1% is finally excreted. So now we also have what are the things which regulate the water? One, the volume, the other the osmolarity. Volume regulates through the angiotensin formation. Angiotensin 2 is a dipsinogen. Angiotensin promotes indirectly AVP release. If angiotensin is there, not only it produces thirst, it also stimulates the ADH so that further water is conserved. Osmolarity is increased means AVP is released, and the AVP leads to less urine produced. Without AVP, we will have water diuresis. That's all we have seen earlier. Because in our presentation in hyponatremia, these were also very essential. So we talked about them. Now, the complex interactions are occurring between the plasma osmolality, plasma volume, the center, kidney, posterior pituitary, and hypothalamus. Now, our today's topic is it deals with three centers: the thirst center, the kidney, and the posterior pituitary. If the posterior pituitary is not secreting the antidiuretic hormone, it is central diabetes. If kidney is not responding to the antidiuretic hormone, it is nephrogenic diabetes. If thirst center is stimulating more water to be drunk, that is the polydipsic diabetes. So, the thirst center, kidney, and posterior pituitary and hypothalamus are the main areas where our diabetes insipidus occurs. Now, what are the diseases where there is a water balance disturbance? Cardiac failure, cirrhosis of liver, renal failure, hyper and hypothyroidism, Addison's disease, CDI, central diabetes insipidus. Hereafter, when we say CDI, you should understand it is central diabetes insipidus. Each time to say central diabetes insipidus, instead of that we say CDI. NDI is nephrogenic diabetes insipidus. PDI is psychogenic polydipsia, or PPDI it is called. PPD, psychogenic polydipsic diabetes insipidus, or compulsive water drink. And pregnancy also is one condition where there is water logging. AC is not working. The system only noticed. Now, till now, nothing new we have heard. Whatever we have covered in the last class, the first class, we have repeated just for recapitulation. Now we are entering into our topic of polyuria or diabetes insipidus. What is polyuria? You must know the definition of polyuria is more than 3 liters of urine per day. More than 3 liters of urine per day or 40 milligrams per kilogram body weight. Pediatric patients, they will not have 3 liters. Then you have to know per kilogram body weight. If the baby is weighing 10 kilograms, 40 ml is per kilogram. So 400 ml or more is polyuria in a baby. In an adult of 70 kilograms, it is 70 into 40, which is 2.8 or 3 liters. So adults, it is 3 liters or more. If it's a 60 kilogram person, it is 2.5 liters. So 2.5 to 3 liters depending on the body weight. Better to remember the body weight, 40 ml per kilogram body. Because some ladies may be 40, 45 kilos only. We can't expect them to have 3 liters per poly. The definition is basically 40 ml per kilogram body weight or 2 liters per meter square. What is how many meters square an adult normally has? 1.75. 1.5 meters square. 2 liters per meter square is 1.5 into 2 is 3. That way also you can calculate. If you know the body surface area, 2 liters per meter square. So babies will have 0.4 meters, 0.5 meters, like that, or 0.3 meters will be there. So, what are the physiological conditions which can alter the urine output? Stress. You all know before examination, you will be visiting the toilet again and again. In the 5 hours you sit. You would have just now entered the bathroom. Again you feel like going. All of us are. Or when we are hurrying, exercise. Also, what will happen? Exercise, perspiration will occur. Lot of fluid is lost. Urine volume is decreased. In summer, perspiration occurs. Urine output is less. In winter, the other way around. No, there is no perspiration and more urine you have to excrete. So depending upon whether winter or summer, exercise or stress, the urine volume might physiologically change. That we are not worried. That is why we are keeping 3 liters and above as the cutoff. Normal is how much? Only 1.5 liters. What is the normal bladder capacity? How much urine you can hold? Around 200 to 250 ml. Upper limit is 300. Women have a lower bladder capacity compared to men. So how many times you urinate in a day? Maybe around 3, 4, 5 times. In the night, maybe 1, 4 plus 1, 5. 5 into 200 is 1 liter or 1.5 liters. That is the urine excretion. Normally, okay. Polyuria generally is associated with polydipsia. Polydipsia is increased thirst. Dipsia. Polyuria is usually associated with polydipsia. Polydipsia or PD, there is a definition for that also. When I say polydipsia, when a person is drinking more than 6 liters per day, that is 60 kilogram person, 100 ml per kilogram into 66 liters per day. It's very, very easy. More than 3 liters is polyuria, more than 6 liters consumption is polydipsia. 3 ends approximately. But of course, depending on the body. Okay, you always titrate. For babies, what is polydipsia? A 10 kilogram baby, 100 ml is the 100 ml per kilogram into that is 1 liter itself is polydipsia. So you have to remember per kilogram, more than 40 ml per day is polyuria, more than 100 ml per day is the polydipsia. Then you have to separate now polyuria from frequency of urine. Frequency of urine is what? Number of times visiting the toilet. That is frequency of urine. Frequency of urine is passage of small quantities of urine. It will have many causes. What are those? Urinary tract infections. Lower urinary tract symptoms will be there. LUTS, lower urinary tract symptoms. LUTS means they will have burning, they will have itching, they will have a number of times they will pass, they will have pain while passing the urine, burning, pain, painful micturition. All that is LUTS, occurs in UTIs, urinary tract infection. So what will happen? Somebody says, sir, I'm visiting the toilet more than 10 times a day. I think I have a problem with the water. Yeah. Do you have burning micturition? Yes. Already, do you pass small quantities, more number of times? So frequency rather than polyuria. Second one is benign prostatic hypertension. Very common in men of my age or around 60 years. So people will have prostatic enlargement. The prostate enlargement is obstructing the urinary tract. They will empty 100 ml and residual urine still remaining. After 1 hour, 2 hours, they again have to empty. This increases the frequency because of the urinary tract outflow obstruction. Urinary tract outflow obstruction, mainly due to the BPH. Urinary stone disease also increases the frequency. People who have urinary stones, the stones will be irritating the bladder wall, the cystitis may be there, the trigone is irritated by the stone, they have the urge to go visit the toilet. And of course, urinary incontinence, neurogenic bladder, other causes of neurogenic incontinence. One day we will take up the bladder innervation. Very difficult for all of you. So I will tell you simply what are the various nerves, those both somatic and sympathetic and parasympathetic nerves, which control the bladder function. Bladder function is a very important function. And how it is controlled, we will look at that in a separate. Okay, UTIs, BPI, urinary stones, and urinary incontinence are some of the causes of polyuria with frequency. Commonest of the frequency is associated with polydipsia and polyuria. Diabetes mellitus. Diabetes mellitus is the commonest disorder which produces polyuria as well as polydipsia. Patient will be complaining, sir, night time I'm not able to sleep, sir. 3 times I have to get up. And each time I have to drink water after going to the toilet. That's very common. So we need to exclude diabetes in every patient who comes with polyuria. Okay. What are the four mechanisms by which polyuria can occur? Number one, increase in the fluid intake. Suppose somebody is taking a lot of water, psychogenic reason, or for psychogenic reason, or stress, or anxiety, or you yourself will tell somebody has got fever or something. You drink more water, keep on encouraging the patient to drink more water. When you say more water, if you ask him to drink 2.5 to 3 liters, he thinks doctor has advised, he has said more 3 times, so I must drink at least 6 liters. Naturally, you will have polyuria. That is, increased fluid intake, either iatrogenic or psychogenic or stress. Whenever we are stressed, though we are not thirsty, we keep on drinking water. Take half glass of water, then they have not yet called me for YOC. I am stressed, one more glass of water. Okay. And then increased glomerular filtration. There is hypermetabolic state, there is fever, there is hyperthyroidism. Instead of 120 ml per minute, it goes up to 180 ml, 190 ml. More is filtered. Naturally, it cannot absorb everything. More urine has to come. So polyuria, four mechanisms. One is the intake of the fluids has increased. The other is increased GFR due to hypermetabolism, hyperthyroidism, or fever. Number three, increased output of solute. In the urine contains more of solutes. For example, sodium is there. Along with the sodium, water has to follow. When Rama goes, Sita also follows. Like that, whenever the solute is there, along with the solute, the solvent also. The solvent is the water. If there is more urea or more nitrogenous end products, more calcium in the urine, in order to go with the solute, the solvent also, the water also has to go. That is called increased output of solute. The most important solute that goes in the urine and takes water with that is sugar. In diabetes, what will happen? The solute, sugar is there in the urine more. In order to accommodate the free passage of the sugar, more amount of water also. Hyperthyroidism, hyperparathyroidism because of hypercalcemia. Supposing you have given diuretic. These diuretics, what they will do? They will increase the solute load at the DCT. How do the diuretics act? All of them, they prevent solute absorption in the PCT and the loop of Henle. In the DCT, more sodium, more calcium is presented. And because the sodium and calcium have to go, water also will have to. That is how the diuretics act. So diuretics acting on the DCT. And lastly, our favorite topic of today, inability of the kidney to reabsorb the water in the DCT. DCT reabsorption of water is under the control of ADH. So there is a failure of the pituitary to secrete ADH, that is central diabetes insipidus, or the kidney is not responding, that is nephrogenic diabetes insipidus, or there are certain drugs which can cause the kidney's inability and the chronic renal failure. These are the causes of inability of the kidney to reabsorb water in the teeth. Okay. To recap, increased fluid intake, psychogenic, iatrogenic, stress, anxiety. Increased GFR, hypermetabolism, fever, hyperthyroid. Increased output of solutes, commonest increased output of solute is sugar, diabetes, hyperparathyroidism, calcium, hyperthyroidism due to hypermetabolism, and then other solutes also are increased there. Diuretics, they present more solute at the DCT and that produces more water too. Inability of the kidney to reabsorb water, because water reabsorption in the DCT is in the hands of ADH. If the ADH is not secreted from the center, then that is central diabetes insipidus. If it is not properly working and the kidney is not responding, it is called the nephrogenic diabetes insipidus. And then drugs and CR. Okay. Now, what are the points in the history that are essential for me to dissect the differential diagnosis of polyuria? Is it increased volume or increased frequency? That settles 50% of the cases. UTI, stones, BPH, outflow tract obstruction, all these things are separated by number of times versus volume. Is there associated polydipsia? This again tells if there is associated polydipsia, more urine volume has gone. That is why the thirst center is stimulated and then he is drinking water. Weight loss is there in the patient, suggests malignancy or diabetes. There is family history of diabetes or diabetes insipidus is there, then that is supportive to one of the diabetes. He says, both my parents are diabetic. I have come with polyuria now. Means what? Probably he is also a diabetic. He or she. Okay. Past history of, most important, this one. History of neurosurgery, meningitis, head injury, psychiatric illness. All these are important in the past history. Drugs like lithium, analgesic abuse, analgesic nephropathy and analgesic abuse, vitamin D, hypercalcemia, nephrotoxic drugs, and in the modern world, SGLT inhibitor. So you wanted to control the blood sugar by excreting more sugar using SGLT inhibitor. But we know glucose is a good puller of water. So when more water, sugar is going in the urine, water also is. The first complaint SGLT man will come, sir, earlier I am getting 2 liters, 3 liters of urine, 2 liters, 3 liters. Now after your medicine, instead of getting controlled diabetes, my urine outflow. Yes, that's how it's supposed to be. Okay. Recurrent infections. Because of diabetes mellitus, recurrent infections may be there, and history of hypertension, CKD, hypercalcemia, urinary tract obstruction, polycystic kidney disease. So what are all the conditions that I need to remember as far as the history of the patient of polyuria is concerned? One is there an increase in the volume or frequency? Is there associated polydipsia? The history of weight loss suggests me he may be having uncontrolled diabetes or malignancy or hyperthyroidism also. Isn't it? Hyperthyroidism also you can add because that can produce polyuria and also weight loss. And then family history, diabetes mellitus, diabetes insipidus. History of neurosurgery, meningitis, head injury, psychiatric illnesses, compulsive water drinking should be elicited. Drugs, particularly lithium, and long-term analgesic use, vitamin D, hypercalcemia, and the nephrotoxic drugs, SGLT inhibitor. Then recurrent infections due to diabetes, and then you have the history of hypercalcemia or CKD, or hypertension, urinary tract outflow obstruction, polycystic kidney disease. Okay. Now, I come to physical examination. Again, look for signs of wasting and cachexia, diabetes insipidus, diabetes mellitus, malignancy. Skin manifestations may be there due to underlying cancer or due to diabetes. Nails, clubbing of the nails, CKD nails, carcinoma bronchus will have clubbing nails. Anemia usually is anemia of CKD is normocytic normopathy. Malignancy anemia, lymphadenopathy, infiltrative disorders, and malignancy. Fundus examination is a must in all patients of diabetes, insipidus or poly. This is to exclude hypertensive and diabetic changes in the fundus, and particularly retinopathy changes and papilledema. You can see the wasting there, ascertain wasting or cachexia as it occurs in DM and DI, and malignancy look for skin changes, particularly in cancers and diabetes. They will have fungal infections, itching all over the body, and these things. Nail examination for the clubbing. Then you have to have the hemoglobin examination for anemia, as it occurs in CKD and malignancy, and lymphadenopathy in the neck and the axilla, particularly infiltrative and other malignancy disorders. Fundus examination for retinopathy. Now, how can I classify polyuria depending on the cause? Yes. Endocrinal causes, renal causes, iatrogenic, metabolic, psychological, or psychogenic, other causes. Endocrine causes, diabetes mellitus, TDI, and Cushing's. TDI is central diabetes insipidus, diabetes mellitus, and Cushing's also they will have polyuria. Renal failure. Renal causes chronic renal failure, relief of the urinary tract obstruction, chronic pyelonephritis, nephrogenic diabetes. Insipidus CPN is chronic pyelonephritis. Nephrogenic diabetes, insipidus Fanconi syndrome. This Fanconi is also a very big confusing thing to all of you. I will take one class probably on Fanconi because you must know what are all the tubular defects that occur in Fanconi. Metabolic, hypercalcemia and potassium depletion. Increase in the calcium, lower potassium can produce polyuria. Psychogenic, compulsive water drinking, or PPD. That is polydipsia associated with polyuria as PPD, and the other causes are systemic venous thrombosis and then sickle cell anemia. Now I have just given a diagrammatic illustration. Endocrine, CD, CDI, DM, Cushing, metabolic, calcium, hypercalcium, potassium depletion, psychological, PPD, CWD, others, there is venous thrombosis, sickle cell anemia, iatrogenic drugs, diuretics, lithium, tetracyclines, and alcohol, and then SGLT inhibitors, renal, CRF, NDI, Fanconi, chronic pyelonephritis. Under the drugs, it is not here listed, SGLT also. You can add in the slide. Now, my problem is the posterior pituitary at fault, or is the third center at fault, or is the kidney? This is how I have to evaluate. And there is one condition called the gestagenic diabetes insipidus. Just like gestational diabetes, in gestagenic diabetes insipidus, in the pregnant woman also it can occur, particularly in the first and second trimester. Once they come to the third trimester, it gets corrected. And after the delivery, unlike diabetes mellitus, in the gestational diabetes, it won't progress on to diabetes mellitus after delivery. And it will stop after the delivery. The moment the childbirth occurs, diabetes disappears. Whereas diabetes is not like that. Gestational diabetes, 100 women are there. Around 30-40 of them will continue to be diabetic patients after delivery also. Okay. Now, we come to our story. Diabetes insipidus. Diabetes insipidus refers to an abnormal state of water, and it is not an osmotic diuresis. What is osmotic diuresis? When there is more solute, let's say calcium or sodium or glucose, along with it the water going is mannitol or any osmotic substance producing diuresis called osmotic diuresis. It is not osmotic diuresis. There is no increase in the solute load, but the water is going without there being solute on its own, and that is called diabetes insipidus. Is an abnormal water metabolism state, and it is not due to solute diuresis or osmotic diuresis. And remember, diabetes insipidus could be a very important marker of an underlying tumor in the brain. It's not a simple condition. It could be underlying brain tumor. In fact, around, I remember, 15 years back, one patient we started investigating, and it turned out to be polyuria and then diabetes insipidus. And the MRI we did, we found out the reason is central diabetes insipidus due to a tumor in the brain. The presenting feature is polyuria. He didn't have anything else. So he came with polyuria and we evaluated and found out brain tumor. Okay, abrupt onset of polyuria and preference for cold or iced water. It also suggests central diabetes. Sir, I was normal last week, urinating normally only. Only last 4-5 days, my urine volume probably is 4 times or 3 times. And also I feel like drinking always ice water, even in this weather of 20 degrees temperature, I prefer to drink ice water. That is a sign that probably we are. Then another condition called the pagophagia. What is pagophagia? licking the ice. They take the ice cubes, keep on licking the ice. This is a pica. Pica, pica is abnormal, perverted taste is pica. Like ball paint or mud or anything, ash or chappies, something like that. Eating all those things is pica, especially in iron deficiency. And pagophagia is also one form of pica. These people will not have pagophagia, but they will have craving for ice water. The difference is, okay. Different diagnosis of diabetes insipidus is sometimes missed for years if it is mild. If it is mild nephrogenic diabetes insipidus, you may not even know. He may think that it is normal to go 10 times to the washroom. He may not even complain. You may not investigate. Diabetes insipidus has 4 main types: central, nephrogenic, PPDI, gestation. So we are now boiling down to 4 types of diabetes insipidus. Central diabetes insipidus, nephrogenic diabetes insipidus, polydipsic diabetes insipidus, PDDI. Because of polydipsia, of any reason, polydipsic diabetes insipidus, and gestational diabetes insipidus or gestagenic diabetes. It's called gestagenic rather than gestation. Why it occurs, I will show. Now, central diabetes insipidus. It is neurogenic because it is from the brain. There the hypothalamus or the posterior pituitary is not secreting the ADH in enough quantity. Arginine vasopressin, ADH secretion itself is decreased. When ADH secretion is decreased, there is nobody who is conserving the water. So diuresis occurs. Anti-diuresis not there, so diuresis. That is the mechanism in central diabetes. The most important differential diagnosis is CDI. Here, the volume of urine is 10 liters per day, 8 liters, 9 liters, 10 liters. What is the capacity of the bladder? 200 ml. 1 liter is 5 times. 10 liter is 50 times. 50 times in 24 hours. By now, after we sit here, we have to go to the toilet. In the waking hours, it's even more. So very cumbersome. The urine volume, depending on the urine volume itself, you can say it is central. The urine volume is more than 8 liters, you can swear it is central diabetes. Okay? Central diabetes insipidus is due to the defect in the ADH secretion. Because the antidiuretic hormone not there in sufficient quantity, either it is absent or reduced, there is diuresis that produces polyuria. And polydipsia is a definite accompanying sign in central diabetes. Because so much of urine is going, he has to replace the fluid. Polydipsia is. The second one is nephrogenic diabetes. Nephrogenic diabetes. ADH secretion is all right. Pituitary is producing normally posterior pituitary, but the kidney is not responding. Kidney says, I don't want to listen to your order. The ADH comes and tells the kidney, you conserve water. The kidney, no, I don't want to listen. Adamant. Kidney is adamant and it is listening. Due to various reasons. Due to kidney disease, due to arginine vasopressin receptor mutation itself, due to various causes. Okay? The nephrogenic diabetes, the culprit is the kidney, and usually the urine volume is around 4 liters. It is not 10 liters or 8 liters like that. Okay. The third one is primary polydipsic diabetes. Okay, primarily polydipsia. The primary reason is pituitary is normal, kidney is normal, the fellow is drinking water more. There is no defect in the ADH from the pituitary, nor the kidney is also not refusing to accept the orders of the pituitary. They are all right, but then this fellow is consuming 8 liters of water because of some reason, and that is causing the polyuria. Why he produces? Either he is dipsinogens in the body or he is psychogenic. Dipsinogenic, psychogenic. Psychogenic means psychogenic compulsive water drinking. People have some psychiatric illnesses. They keep on drinking more amount of fluid. Dipsynogenic means certain dipsynogens, particularly angiotensin II stimulating substances, are those which produce dipsynogenic polydipsia. Iatrogenic, I ask him to take more water, drink more water, drink more water. Or I have put it this one and ask the nurse to infuse half a liter in whole day. Now she says patient will have a lot of strength. Let me give 6 bottles before the doctor comes. She infuses 6 bottles because he says each bottle is very strengthy. Most people also feel like that. I'm feeling very weak. Give me glucose. Or IV fluid, they will think. But the IV fluid directly enters the circulation. Why? So iatrogenic, excessive IV fluid, or excessive drinking by the patient due to the doctor's orders, or polypsychogenic, or dipsynogenic, and gestagenic. Gestagenic is because there is a substance called vasopressinase. Vasopressinase means a scissors which cuts the vasopressin. If you have scissors for thyroxine, thyroxinase. If angiotensin scissors, angiotensinase. Here vasopressinase. So this scissors, what it will do? It will cut the vasopressin. Whatever vasopressin is produced from the pituitary, the placenta coolly cuts it. And there is no vasopressin available in the body to conserve water. So placenta is at fault, and that is producing a vasopressin. As I told you, first, second trimester it will occur, fourth, third trimester it will get corrected after delivery. Okay. Now, we go more into more details about the CDI. Now we have basically understood in the first few slides where is the fault and what is the fault. In the CDI, the pituitary and the hypothalamus are at fault. There is decreased production of the ADH. Okay. Now, what are the causes in the central diabetes? It's not one group of disorders. Many. Remember, in central diabetes insipidus, 90% is acquired. Only 10% is genetic. In nephrogenic, the other way around. 90% is genetic. Only 10% is acquired. So, then what? If an nephrogenic diabetes insipidus fellow comes, call how many brothers and sisters? 3 fellows, come, bring all of them. You have to investigate them. Your parents, come, you have to investigate them. Because most of it is genetic in nephrogenic. Whereas here it is not genetic, more acquired. Acquired due to what? Brain tumors, head injuries, granulomatous diseases of the brain, autoimmune disorders of the brain, tubercular meningitis, very common condition which can produce central diabetes insipidus. So these are the acquired causes. Inherited causes, genetic mutations of the vasopressin gene itself. The vasopressin is coded by a gene. That gene is genetically mutated. It could be AD autosomal dominant or recessive or X-linked. All 3 types are possible. These are only 10% of CDI or genetic, 90% are acquired. The evaluation centers around brain imaging and history. Okay? Then idiopathic. You may not find any reason. There no acquired cause is there, no inherited cause is there, but for some reason the ADH secretion from the pituitary is less. That is called idiopathic. Okay. Now, central diabetes, lack of ABP production and secretion. So it's either not produced or not secreted into the circulation, may be complete, may be partial. Usually the urine volume is more than 8 liters to 10 liters, as I told you. Polydipsia is an accompanying troublesome feature. Disturbance or injury of the hypothalamus and pituitary is the potential cause. Causes are idiopathic, traumatic, neoplastic, cyst, inflammation, autoimmune diseases, TB meningitis, all. How do I distinguish? These people are usually adults. They are not children. CDI patients are usually adults. They have an underlying history or clinical feature suggestive of brain disease, like trauma, neoplasia, cysts, inflammation, meningitis, any one of these. And urine, this ADH secretion is either partial or completely absent. Urine volume is very large around 8 to 10 liters, means around 50 times or 40 times he has to urinate in a day. I can imagine the fate of a fellow who has to urinate 40 times in a day. That means he's almost sitting in the bathroom. They're not coming out. The moment he comes out, again he has to go. So very troublesome. Okay. Polydipsia is an accompanying feature because of large amount of polyuria. Polydipsia is an accompanying feature. Underlying injury to the hypothalamus or pituitary is usually available. Now, we need to know a little about the V2 receptor. This V2 receptor is where? It is in the kidney. It is in the distal convoluted tubule. The cell is like a basal side and an apical side. On the apical side, the V2 receptor is sitting. This V2 receptor, there is a long chain there you can see, that is called the V2 receptor protein. That protein is plicated. Plicated means folded. Madata. That is, fold your dress, you fold to keep it in the suitcase for journey. A long shirt, you fold it into this much size. Like that, the protein is folded. And when the protein is folded, it produces some areas for the AVP to come and sit there. So the folding produces some mold-like thing. Into that mold, the AVP comes and nicely. Suppose it is misfolded, then there is no place and the AVP cannot come and sit there properly. And lock and key arrangement doesn't occur. When the lock and key arrangement doesn't properly fix it, the AVP comes there, but then finds the receptor is not properly accommodating it to sit. So that is a AVP receptor mutation. This has been very recently recognized. Last 15 years only, we know that a V2 receptor mutation. After Peter Agre's work on aquaporins only, this was identified. Earlier, we were not knowing that this receptor protein plication mutation is the cause. It is published in 2006, first time in the JASN, Journal of American Society of Nephrology. Usually, I give the annotation also. One can go and read that article. I have circulated the PPTs of last class. What is that class? We had Niponet. One class 1 and 2, one PPT, both together, and then 2 videos also I have posted. This PPT also I will circulate. Okay. So, in nutshell, what is central diabetes insipidus? Central diabetes insipidus is due to a problem in the hypothalamus or brain. Usually occurs in adults. 90% of times acquired, 10% of times it is genetic. Acquired causes are infection, cyst, tumor, inflammation, autoimmune, trauma. Just like any disease is there, infection, trauma, tumor, cyst, inflammation, autoimmune. Same way here also. Underlying cause will be evaluated, sometimes idiopathic cause. Now, distinguishing feature is adult onset and then very large volume of urine, 8 liters to 10 liters of urine, very cumbersome. Associated polydipsia is a feature and there will be wasting. Lot of wasting, cachexia will be because of such amount of fluid loss. And then when I evaluate, my evaluation will be mainly focusing on the hypothalamus and the brain disorder. Nephrogenic diabetes insipidus, it presents in children, it could be congenital or acquired, 90% congenital, 10% only acquired, there 90% acquired, 10% congenital. So, young children, months babies, born babies, they will be the ones who are affected. What is the problem? V2 receptor protein misfolding, which is called V2 receptor vasopressin receptor mutation. 180 odd the mutations are documented. That means this misfolding can occur in 180 different ways. And where is the gene? It is located in chromosome XQ28. Okay, X chromosome, the Q arm, XQ28. Protein misfolding is the V2 receptor, not translocated to the basolateral membrane of the CT. What does that mean? This is the cell. This is the basolateral membrane. This is the receptor here. And this receptor has to be stimulated. And when it is not properly stimulated, it's mutated. The cyclic AMP is not activated. The vesicles are not thrown open to the basolateral membrane. The vesicles are not translocated to the basolateral membrane. Why? No CMP. Why so no CMP? But he is telling receptor is sleeping. Why receptor is sleeping? The arginine receptor is not able to sit there because this is how it happens. Okay. Now, not translocated to basolateral membrane of the collecting duct, 90% is genetic, 10% are. What are the acquired causes? Acquired NDI due to hypokalemia and hypercalcemia. Hypokalemia, hypercalcemia, bilateral urinary tract obstruction, lithium therapy, acute renal failure, advanced CRF, polyuria of acquired NDI is of moderate degree, 4 to 6 liters. Unlike there, 8 to 10 liters. Okay, here it is not. And you will have, if it is genetic, the child will commonly occurs at birth. Very young children, months babies, newborn babies, neonates, urinary frequency is increased, nocturia, enuresis, constant thirst, baby is crying for the breast. Just now she is fed, baby. Another 5 minutes later, again crying, again mother goes on nursing the baby. And the diapers are have to be changed very often. Patient cannot tell, no, I am having thirst, the baby cannot say. And baby cannot say, I am urinating more, that also she cannot say. Very cumbersome. Only the attendant, the mother will recognize that the diapers have to be changed. In the first issue, when I had that fellow, the boy, I used to change the diapers once in 2 hours. This girl, when she is born, I have to change every 2 minutes. She is passing urine. More number of need to nurse the baby. More often, inconsolable crying. Baby keeps on crying because of thirst. Crying is one way of expressing their hunger or thirst. So, usually wet diapers, inconsolable crying, frequent need to nurse, dry skin, cool extremities, failure. Usually it is these babies, unless recognized early, they may not survive because of extreme degree of water. So, it's a very different picture. Central diabetes insipidus, nephrogenic diabetes. The cause is very different. The presentation also is very different. Now you understand. Probably nobody would have told you so clearly this diabetes insipidus, how to separate clinically and also the cause-wise and etiology. Then the polydipsic diabetes. Polydipsic diabetes insipidus is acquired diabetes insipidus. Idiopathic, mostly there is no specific cause. It could be dipsinogenic, it could be iatrogenic, it could be psychogenic. Chronic meningitis, granulomas, other diseases, multiple sclerosis, diffuse disorders of the brain, these can produce dipsinogens and can produce this. Psychiatric illnesses, central water, compulsive water drinking, or primary polydipsic diabetes. This is polydipsic. Then you have the fourth variety called gestogenic placental vasopressin. This polydipsic diabetes insipidus usually acquired not genetic causes, and it can occur any age, particularly in the adults. And for the psychological ones manifest more in the adults. Okay. Now, what is the first step to evaluate? To separate polyuria from solute diuresis. Solute diuresis usually is less than 3 liters. Polyuria is more than 3 liters per hour, per 24 hours. Then what do I require? 24-hour water collection, urine collection. So you have to give him a can, not 1 liter bottle like this. If you give 1 liter bottle, 10 liters is his urine, he will bring 10 bottles. And it is very cumbersome. So at least a 5 liter bottle we have. The department, if you go there, they have a can. They'll put some chemical inside so that the urine doesn't disintegrate. And usually the chemical is acetic acid. 10% acetic acid added to the bottle. 10 ml of 10% acetic acid you add. And clean water. That bottle you have to give and label and give it to the fellow. What he has to do? He has to carry that 24 hours wherever he is going. If he is going to mall, he must carry, because if he gets washroom, then he has to use the bottle. So better you, preferably on a day when he is at home, you make the collection. It becomes easier. Then he should not keep it in his bedroom or in his hall. He should keep it in the wash. So he or she, when she gets the bathroom, they should remember to collect the urine in that. Many a time, if you have to collect 24 hours, you may forget and urinate in the toilet itself. Then that urine is not added, you will not get the proper evaluation. So these are the precautions I'm telling, practical precautions. Labeling is important. 10% acetic acid has to be added, and then the bottle should be given in 5-liter denomination, and this 5-liter bottle should be in the washroom, which the patient commonly uses. Do on a day when the patient is at home, not when he is in the aircraft or going in the mall or something. Okay. Now, what is polyuria? More than 40 ml per kilogram body weight is polyuria. That means I have to take the weight of the fellow, and depending on that, multiply by 40, 50 kilogram fellow, 40 into 50, 2 liters. He brought 4 liters, polyuria. Finish. And I have to measure, what is it, dilute urine or is it concentrated urine? If it is concentrated, means it is solute is there. More solute, either potassium or calcium or glucose or urea, some solute is there in that. How do I know the osmolality, whether it is concentrated or not? I do the urine osmolality. How to do the urine osmolality? You know already. Sodium plus potassium multiplied by 2 plus glucose, usually not there. If it is there, divided by 18. There is no bun here, there is urea, and that divided by 5. So I've told you last time. So you calculate the urine osmolality or give the urine for osmolality, they will give you the value. So the first step is collecting the 24-hour urine and then deciding whether it is more than 40 ml per kilogram body or not. If that is satisfied, that means he is having poly. Then next question is it with increased solute or less? That means what is the osmolality of the urine? So actually I have written in one textbook of medicine, the topic of diabetes insipidus and polyuria. One chapter on this is written by me in one textbook. I'll give you that reference. So I contributed to several textbooks in the chapters. One of that is this topic. It came out very well. So now, polyuria is equal to more than 40 ml per kilogram body weight per day. Urine osmolality is less than 300 milliosmoles. Urine specific gravity you can measure, but specific gravity is not such a robust measure, and osmolality is a good measure. PD is the drinking of more water, polydipsia. You have to ask him. And then along with the collection of urine, he should also measure and tell me how much water he has taken. Apart from his food, food contains anyway some water, we know, around 30% of 20%, 30% is from the food. But main is through the mouth. So he should measure whatever he is taking, coffee, Bournvita, Horlicks, Coca-Cola, water, whatever he is taking, he can take, but then he should write this. 10 ml, 100 ml of water, coconut water, 200 ml of coffee, like that he will write and bring it tomorrow and he comes. That gives me whether it is exceeding more than 100 ml per kilogram. That means polydipsia is there. And also I require plasma sodium because this is one variable which will help me to differentiate whether it is due to the hyponatremia, all this problem is coming. So I require to know the serum sodium. The next thing is algorithmic approach. That is how to go about step by step. So this will take another 45 minutes or 1 hour. I don't know whether we have that much time now. We will stop here. We have primed you with all the background material of say CDI, NDI, PPDI, gestogenic diabetes insipidus, clinically how to differentiate, what are the history points you should look for, what are the examination points you should look for, what is the basic investigation you require, 24-hour urine, 24-hour fluid intake chart. We require both. How to collect 24-hour urine, I have told you. And along with that, urine osmolality, serum sodium also are measured. Using these variables, we will go into the algorithm. Something like that, we will go into the algorithmic approach, Hickory test, AVP replacement, treatment also we should know, and then a lot of slides are there. We will have a look at those things in the next class. Till now, any questions you have? Have you understood water balance, polyuria, how it occurs, the three compartments, and there is an interaction between them, the hormones which move this fluid like that, the handling of the kidney, collecting duct, AVP receptor, how the arginine vasopressin acts on that, and what are the four types of frequency, how do you separate frequency of urine from polyuria, and then once it is polyuria, is it central or nephrogenic or PPDI or gestogenic. Gestogenic very easy, woman is pregnant and she is in the first trimester. Second trimester, she says, sir, before pregnancy, my urination was like that. Now, naturally, because of the uterus pressure, there will be more frequency for pregnant women. That should not be mistaken for polyuria of pregnancy. Measure 24-hour urine, if it is more than 40 ml, then only it comes under. But just simple frequency is always there and around in early pregnancy, particularly in the second trimester. They keep on complaining if the bladder capacity is reduced. So they need to visit the toilet. So keep those things in mind. Now we go to the algorithmic approach in the next class. Try to be punctual by 2:30 itself so that we will complete it early. And so if you have any doubts, I will clarify. Is it useful or what? Going inside, not leaving. Okay. The thing is, it should enter. Enter should be retained. Retained should be recalled. Whenever I ask you to write an essay on polyuria, then you should be able to write out. And also, not only just have the theoretical knowledge, the background practical information, how things are happening, and what will be my attempt at treatment, all those things. For example, compulsive water drinking is there. Treatment is not giving arginine vasopressin. You should address the underlying disorder. Why he is drinking more water? Some psychological issue is there, or some dipsinogen is causing, or some hydrogenic fluid overload is there. That has to be corrected. If there is a deficiency of the arginine vasopressin, I can supplement. If the kidney is at fault, giving arginine vasopressin is no use because how much amount of vasopressin I give, the receptors are folded, they are sitting like this, they are not accepting the vasopressin, then what do I do? So the treatment depends upon the pathogenesis, how it occurs. For that reason, you have to understand the pathobiology and pathophysiology of this, isn't it?